We'll now transition from infections and or infectious and autoimmune testing to tumor markers. These are laboratory indicators that are associated with malignancy. And these tests measure substances produced either directly by tumor cells or by normal tissues in response to cancer. While not a lone diagnostic, tumor markers can guide screening, monitor treatment, and detect recurrence. A tumor marker is any biologic molecule, protein, enzyme, hormone, receptor that can be measured in blood or body fluids and may indicate the presence of cancer. Ideally, a tumor marker would be tumor specific, detectable at low concentrations, and absent in healthy individuals. Unfortunately, no marker meets these criteria, so results must be interpreted in context with imaging and biopsy findings. A tumor marker is detected through a variety of immunoassay methods, ELISA, chemiluminescent assays, and these markers often increase as tumor burden progresses. They could even peak with metastasis. However, benign conditions can also elevate these markers. For example, inflammation, liver disease, pregnancy can cause false elevations. Therefore, serial measurement over time is more meaningful than a single result. So when do we apply use of a tumor marker? Well, in screening, they can identify individuals at high risk. For example, PSA in prostate cancer or CA-125 in ovarian cancer. In diagnosis, they complement imaging and biopsy. For prognosis, higher levels often indicate advanced disease. Finally, during treatment monitoring, declining marker levels suggest therapeutic success, while rising levels may indicate reoccurrence or resistance. Common tumor markers are listed on this slide, and there's many more. Some are organ specific, while others are more general indicators of malignancy. Genetic markers like BRCA1 and 2 are not circulating proteins, but mutations associated with increased cancer risk. Understanding which marker applies to which malignancy is key for clinical interpretation and also for your NPLEX exam. Alpha-fetoprotein is normally produced by the fetal liver and yolk sac, but elevated levels in adults suggest certain malignancies. It's particularly important for hepatocellular carcinoma and non-symptomatous testicular tumors. Normal levels are less than 10. Levels above 400 strongly suggest malignancy. A mild elevation can also occur in hepatitis or cirrhosis. It serves several roles: diagnosis and monitoring of hepatocellular carcinoma, screening high-risk populations like patients with chronic Hep B and C, or assisting testicular and ovarian germ cell tumors. In hepatocellular carcinoma, AFP may exceed 4,000, and levels should return to normal after successful treatment. Persistent elevation post-therapy suggests residual disease or even recurrence. In combination with beta HCG, AFP helps classify and monitor non-semitomatous germ cell tumors. Elevated AFP can also appear in certain ovarian cancers and mediastinal germ cell tumors. Although AFP is sensitive for liver and germ cell tumors, it lacks absolute sensitivity, so confirmatory testing and imaging and biopsy remain necessary for diagnosis. Human chorionic gonadotropin is a hormone that's normally secreted by placental trophoblasts during pregnancy. And in oncology, elevated HCG levels indicate gestational trophoblastic disease, testicular and ovarian germ cell tumors, or choriocarcinoma. When used alongside AFP, HCG aids in diagnosis and treatment monitoring. And serial declines in HCG during therapy suggest effective treatment response. CA-125 is a glycoprotein used to detect and monitor ovarian cancer. Elevated levels often precede clinical progression, making it useful for early detection in high-risk patients. However, CA-125 can also rise in non-malignant conditions like menstruation, pregnancy, or endometriosis. The normal cutoff is less than 35. Tracking trends over time is more informative than a single measurement. CEA is one of the most widely used tumor markers, primarily for colorectal cancer, as it assists in prognosis, post-op surveillance, and monitoring response to chemo. Normal values are less than 5.5, and higher levels can indicate advanced disease. CEA can also be elevated in lung, pancreatic, or breast cancers, emphasizing the need for specificity through imaging and pathology. While helpful in monitoring, CEA lacks specificity. Elevations can occur in benign conditions as well, like hepatitis, COPD, pancreatitis, even tobacco use. Therefore, a mildly elevated CEA in the absence of imaging findings should not trigger panic. Instead, focus on the trends. A consistent rise over serial tests suggests reoccurrence or metastasis in known cancer patients. HER2/neu encodes a growth factor receptor that, when overexpressed, promotes tumor proliferation. It is a critical marker in breast and ovarian cancer. HER2 testing is performed on tumor testing or tumor tissue using immunohistochemistry or fluorescence in situ hybridization. FISH. HER2 positivity identifies patients who benefit from targeted therapies like trastuzumab or Herceptin, and approximately 1 in 5 breast cancers overexpress HER2. For hepatocellular carcinoma, the key marker would be AFP. For ovarian cancer, the recommended markers would be a CA125 and in a hereditary case, BRCA1. These markers are useful for both diagnosis and longitudinal monitoring. BRCA mutations signify increased lifetime risk, so genetic counseling and surveillance are crucial for prevention and early intervention. Again, in breast cancer, on the previous slide, commonly measured markers include CA15-3, CEA, HER2/neu, and hormone receptor status, estrogen and progesterone. In pancreatic and colorectal cancers, CA19-9 and CEA are key. Beta-HCG and AFP remain essential for testicular cancer, while PSA is specific for prostate. And you are always combining multiple markers and imaging to improve diagnostic accuracy. No single tumor marker is ideal. Specificity and sensitivity limitations mean that they must never replace a detailed history, physical exam, and confirmatory diagnosis. Use panels of markers rather than relying on one and interpret the results in light of the full clinical picture. The best approach integrates laboratory, imaging, and histopathologic data for accurate cancer diagnosis and follow-up. And this ends our lecture on immunologic testing. Today we've gone over a lot: autoimmune serologies, infectious disease, immunoassays, and tumor markers, each representing the immune system's diagnostic fingerprints. Remember that interpretation always depends on context. Test results are tools, not diagnoses. And let's consider any questions you might have and bring them to class next week. We will be applying this information to a case that we're going to go through in class.